Great. Thank you so much, Cameron, and thank you everyone for joining us today for the National Alzheimer's and Dementia Resource Center webinar, Cognitive Stimulation Therapy Programs Directly Supporting People Living with Dementia. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi, everyone. I just want to thank you very much for taking the time out of your busy day to join us to learn about the work we're doing through our ADPI grant program on cognitive stimulation therapy programs. I want to thank Kelsey Akinsinde, I'm sorry, from CareLink. I had practiced it and everything. From CareLink and Stephani Shivers from CaringKind in New York City. We are looking forward to a great presentation, and back to you, Sari.
Thank you so much, Erin. So as you heard, today's presenters are Stephani Shivers and Kelsey Akinsinde. Stephani Shivers is the Chief Innovation Officer at CaringKind, where she leads the development and implementation of new programs and services for individuals and families impacted by dementia. With over 30 years of professional experience in not-for-profit leadership and as an occupational therapist specializing in cognitive function, she is internationally recognized as a community-based leader, bringing evidence-based interventions into real-world practice. Stephani is passionate to drive systems change in dementia services, and she has been the project director on 2 ACL ADPI grants. Kelsey Akinsinde has been a speech-language pathologist providing services for older adults in Rhode Island for 13 years and has a passion for serving individuals living with dementia and aphasia. In her current role as the lead clinician of the Center for Brain Health and Cognition at CareLink, she manages a team of clinicians who provide cognitive stimulation therapy and skills to care in the community. In her spare time, she enjoys beach days and competitive game nights with her family and friends. At this time, I will turn the presentation over to Stephani Shivers to begin. Stephani?
Hello, everyone. Thanks, Erin and Sari, for the opportunity to speak today, along with my great colleague, Kelsey. As they said, my name is Stephani Shivers, and I'm the Chief Innovation Officer and Vice President of Program Development at CaringKind, which is a community-based service organization based in New York City. As many of you know on the call, community-based organizations, or CBOs, have been delivering social supports and education for older adults since 1965, when the Older Americans Act was first enacted. And CBOs, including area agencies on aging, offer a host of evidence-based and evidence-informed programs, including training for caregivers, chronic disease management programs, and falls prevention programs. And since 2012, when the National Plan to Address Alzheimer's Disease was launched, additional resources have become available to build the dementia capability of CBOs like CaringKind and others, including the ACL ADPI project that we're going to be talking about today. As they mentioned, I've actually had the privilege to project direct 2 Alzheimer's disease program projects, and today I'm going to be sharing about the implementation of our cognitive stimulation therapy program, or CST, as we call it for short. ACL ADPI projects always include services for family care partners, and for our current project, Kelsey and I have also included services which directly support people living with dementia. And since we're now in an era of early diagnosis and early stage disease modifying treatments, the opportunity for us as CBOs is really growing to offer services directly to people who are being diagnosed and living with mild cognitive impairment, Alzheimer's, or other types of dementia. And that's what we'll be discussing today. Next slide. To quickly provide some context, next slide, Cameron. You're driving, right, thanks. Oh, go back one. Well, awesome, thanks. To quickly provide some context on who CaringKind is, we were originally formed in 1978 as one of the nation's first not-for-profit organizations focused on dementia, and we were one of the founding members of the National Alzheimer's Association. And for over 45 years now, we've maintained our mission and independent charity status, and we continue to support individuals and families impacted by dementia today as CaringKind. Next slide. Our priorities at CaringKind are really to be a trusted partner for people living with Alzheimer's or any form of dementia, along with their families, their partners, and friends who provide care and support, and also to equip dementia care staff, healthcare and aging service professionals, residential, community, and cultural partners with best practice approaches and resources to serve individuals and families who are impacted by these diseases and disorders. Next slide. We deliver a wide range of programs and services in a variety of ways, including one-on-one sessions, small group programs, education seminars, webinars, targeted training, special events, and our services are delivered in person and virtually, and many are delivered in multiple languages, including English, Spanish, Korean, Mandarin, and Cantonese. All of our services as CBO are provided free of charge to families, thanks to the generosity of our amazing donors and the robust fundraising and grant-seeking efforts our team and board members engage in on an annual basis. Next slide. Our current ACL ADPI project, this is kind of a summary of our high-level objectives and key activities. Our project includes a key objective to implement a suite of early stage programs for people living with dementia, including cognitive stimulation therapy, which is then followed by an ongoing cognitive stimulation therapy maintenance program. Next slide. So what is CST? CST is an evidence-based group therapy program for people living with mild to moderate dementia. It was developed and evaluated by Dr. Amy Spector from University College London. And since its creation 24 years ago, in 2000, CST has been implemented in over 35 countries. It's been extensively researched and evaluated to the point that it's now recommended in the government guidelines established by the UK. And it's the primary psychosocial intervention that's offered in the UK's memory clinics. Research on CST, including randomized controlled trials, those gold standard trials, demonstrates improvements on cognitive function, quality of life, mood, communication, and social engagement. Next slide. CST is guided by 18 key principles, which are listed here. And as a part of the fidelity of the program delivery, CST-trained facilitators are required to incorporate these principles within the biweekly sessions. And since we have limited time today, I'm just going to highlight a few of these key principles. Next slide. During CST, each session follows a similar structure with a main activity on a designated theme. The facilitators guide the discussions and the activities to stimulate different types of cognitive or thinking processes. And the first aim of CST is to provide mental stimulation. In other words, to get people's minds active and engaged. We focus on people's strengths and their retained abilities, and we're less focused on facts with right and wrong answers. Discussions focus on people's opinions rather than facts, and session activities are designed to encourage the generation of new ideas, new thoughts, and associations. We recognize that everyone has different skills, so we use different types of activities to stimulate different types of cognitive or thinking processes. And over the course of the 7 weeks of the program, a participant's whole brain gets engaged in exercise. And through repetition and cognitive exercise, we reinforce then the neural pathways that are retained in the brain, and participants gain the benefits of both peer-to-peer learning and a social engagement experience. Next slide. CST is delivered in a small group format, either virtually or in person, with between 5 or 8 participants and 1 to 2 trained facilitators. There are 14 themed sessions that are delivered twice a week for 7 weeks. And at CaringKind, we deliver CST both in person and virtually. And we added an introductory and a closing session to incorporate our outcome surveys, Zoom training, and to educate care partners who are curious on the program and the ways, and we talk to them about the ways that they can support the independent participation of the person living with dementia. Key point there is independent participation of the person living with dementia. Once participants graduate from their initial CST program, then they can join a weekly cognitive stimulation therapy maintenance group that runs once a week for 24 weeks. And individuals can repeat the CST maintenance program for as long as it's still a good fit for their cognitive abilities. Next slide. With the blessing of Dr. Spector, we at CaringKind made a few adaptations to the original evidence-based format of CST, which I want to highlight for you today. Originally, CST was delivered in person, and Dr. Spector published manuals outlining kind of the key principles and the session instructions for the 14 CST themed sessions, and also for the 24 maintenance sessions. The manuals are still available in the UK, and you can certainly identify the British influences in the activities and in the writing style of the manuals. The manuals include two options for the sessions for the main activity of each session. And one is designed for groups with higher cognitive abilities, and one activity is designed for groups with lower abilities. The manual clearly states that the activities in the manuals are only examples, and that facilitators should identify themed activities that will resonate with the individual group members and align with those 18 key principles, and especially the principles of person-centeredness, respect, involvement, inclusion, and in choice. As we began our CST programs, we met with Dr. Spector and seasoned CST facilitators from around the globe to discuss how they had implemented the CST program in various settings, including what is the UK's equivalent of their AAAs. And we also wanted to leverage existing resources and lessons learned. We also connected with the US Hub for CST in St. Louis at St. Louis University, and CST leaders in New Zealand and Hong Kong who've really been leading research efforts on virtual CST. And these conversations all helped us to identify and shape the activities that were both, culturally aligned and adapted for a virtual experience. We worked with Dr. Spector to just slightly alter the order of the themes for the first virtual session. And we've obviously leveraged PowerPoint, and we incorporate videos and YouTube and audio. And we also streamlined our workflow to include email reminders for the virtual sessions, which included copies of articles, links, activity worksheets, etc. Next slide. So in this slide here on the right, you can see a standard 14 CST themed sessions, starting with, we added the welcome session, and then they progress through. And on the left, you can see the standard outline for an individual session. And to give you a taste of virtual CST today, I thought I'd do a very, very quick drive through of some of the slides which guide our virtual groups. After the webinar, you'll have access to these slides and recordings, so you can definitely review them in more detail on your own time. Next slide. So each week starts with a welcome of every member individually, a reminder of the group name, which they have chosen, and kind of an informal check-in and some warm-up questions. Next slide. Then there's some orientation to the day and to the date, which may include questions like, what day is today? What month are we enjoying? What's the year? Any important events happening? Birthdays, anniversaries, special events in your lives, to ground people in the reality orientation of the here and now. Next slide. We do orientation on the season and on the weather. And because it's virtual, we have folks, tuning in from all over the country. Next slide. And then the group sings their theme song. So in the first session, they choose a song, which they then sing over and over again every week. Next slide. Favorite part of the session is a current events article that is read out loud by various members of the group. And then that article is discussed. And next slide. You can see here was a recent one that was done. This is from the New York Times, which actually had this photograph, and the headline was, "What's happening? Why did 488 golden retrievers gather in Scotland?" And so it was an article about how owners and their dogs travel to the Scottish Highlands every 5 years to celebrate the founding of the golden retriever breed. And we also do current events. We don't shy away from more controversial events. These are adults that are in the group, and they really love engaging in the article dialogue. Next slide. After the article, we do some exercise, and all those elements together take up about 30 to 35 minutes. Next slide. Then we have the main activity, which is based on the session theme. And here the facilitators are really focusing on those key principles of mental stimulation, opinions rather than facts, generating new ideas, thoughts, and association. So here is a taste, of the fourth session, which is on food. Next slide. I can't see if any of you are laughing out there. So here's an activity where we have the group do some, oh, thanks. I see that emoji. So here we have the group do some meal planning activities that incorporate food categories and quantities that align with the current USDA guidelines, which are outlined on a website called myplate.gov. And so they might look at the websites, get oriented to the, like, what are the food groups and what quantities should be there. And then we go on to do some meal planning. And so this, you can see, hopefully, that this activity stimulates cognitive processes of planning and associating and working memory. And we can incorporate kind of long-term memories, which then can be used in comparison to the present. So for example, what kind of things did people eat for breakfast when you were growing up? And then how would those meals align with the My Plate food recommendations? Oh, wait, bad fats, white bread, few grains, so those kind of discussions would then ensue. Next slide. We use a lot of photographs and incorporate sounds to create kind of a multi-sensory experience. And here you see some prompts, describe what you see. What do these pictures have in common? So this provokes kind of the thinking skill of comparison, and sounds can be played and matched or added to compared to the photos or matched to the photos. And we'll play one so that you can get an idea, and you all can put in the chat what you think this sound is and if it matches one of the photos. So Cameron, can you play that sound? And we can't hear the sound, so I don't know if you've heard it. So somebody give me a thumbs up and start chatting. And if not, we'll fake it. Oh, there you go. Awesome. Thank you. Next slide. That's the next sound. You can ignore that, just flip to the next slide. Great, thanks. But you get the idea. So now you've heard kind of two sounds that are associated with those photos. In virtual CST, we have to work extra hard to engage people in a multisensory experience. And so because CST is designed to be a multisensory intervention, and so we may incorporate some visualizations, or we may have people grab things from their own household. We can use some sensory memory techniques on the items that are related to taste and smell and touch and sound. And so in this activity, you see the naming of foods. We ask people to do some naming and to be thinking about things that are foods that are related to things like being sour or soft or sticky or loud or smelly to get the sensory component. Next slide. And here are some items that can be categorized in a number of different ways. So we would ask some questions like, what doesn't belong and why? What's missing? Then you start to grade the activity. What two objects have something in common? What three different objects have something in common? Are there four objects that you can find that have something in common? What two objects are the opposite of each other? And so all of those are, you're trying to, take the group into a level of cognitive stimulation, then go deeper and deeper as they are engaging their thinking processes and cognitive capacities. Next slide. We wrap up the session by doing a quick summary with folks, kind of orienting them to what they've worked during the session. So they've used their orientation skills to identify, where we are in time and date and season. They've used some auditory discrimination skills. They've used their bodies and their cardiovascular system. They're doing some social skills and their creativity with singing. They've created new ideas and associations and shared their opinions. And then, how have they actually used their brains? Is it in the frontal lobe? Is it in the parietal lobe? So we're helping them to identify that, like, what they're doing actually is stimulating their brain in meaningful ways. And then we talk about we close it up with what's happening, what's the next meeting date, what's the theme, and we ask for any suggestions or activities that they might want to include, so we can build the session so that it's meaningful for them. Next slide. We have had next slide, Cameron. Thanks. We get exceptional feedback from the participants who are involved in this program and their care partners. And you can, read these quotes here. And these are just a few select ones, but I'll, highlight, I can be calmer. I don't have to try so hard. This shows me that I can really talk to people. And of course, because you understand, it makes it a lot easier. It's a big thing for me. I love this second quote. The groups I've had the pleasure of being a part of have been a lifeline for me. I have close family and many dear friends, all of whom love me and try to take care of me. Yet there's something so vital, so special about these groups. The smart, knowledgeable, and compassionate leaders, the vital interactions with fellow Alzheimer's diagnoses, the immeasurable value of being truly gotten. Clearly, I can't recommend these groups and the organization highly enough. CST sessions were an anchor in my life. I always look forward to them. These are common themes that we hear in our qualitative surveys and feedback from people. Next slide. Next slide. We do have some early program outcomes that I can share with you on our CST participants, and we'll have our full analysis done next spring once we wrap this project up. So far in our ACL project, we've served 163 people in 31 CST groups. And exciting fun fact for us is that 81% of those participants have been what we call completers of the group. So they've attended at least 12 out of 16 sessions. For our outcome highlights, we've had 63% of our participants were not in the depressed range when they started on the geriatric depression scale. And post-CST, we've had 80% of our participants who are not in that depressed range. So we're definitely moving the needle on depression. And only 8%, which is basically 7 people, declined into the range of being at risk for depression. And 12% started in the risk for depression range and they stayed. But we're excited about those outcomes. And then on the positive psychology outcomes measure, we've had 54% of our participants increased in their overall scores. Post-CST, 52% of them actually maintained or increased their score into the highest range, and 20% declined, but they only declined from the highest range to the next highest range. So they're still in a very high range of overall positivity. And only 2% of our participants declined from those top 2 tiers. It's a 5-point Likert. They declined from the top 2 tiers into a lower range, a 3 or below range. So we feel like we're definitely moving the needle on some things, and we could have a whole discussion on the challenges of standardized outcomes for this population and how they do or don't measure what we're moving the needle on. But that's for another day. Next slide. I did want to share some of the internal program analysis that we've had with you today, some of our challenges, lessons learned, and successes. So some of our challenges implementing CST have included cultivating an appropriate early stage referral. Many people living with dementia are well into the moderate stages when they are referred to CaringKind for services, and particularly in the underserved and minority communities. And so honing those early stage referrals has been a challenge and an area of growth and work for us. Transportation for in-person programming is a known barrier, and this has also been true for us. We've had a much higher demand for virtual CST than we've had for in-person CST. And while adjusting to technology still requires some attention, definitely we've seen an uptick on technology literacy, post-pandemic. And finally, collecting survey data with people living with dementia is always a challenge, and with virtual programming, it's even more difficult. So one of the lessons that we have learned is to collect survey and data information via interview and to incorporate it into a live session or into the intake process. Then we can at least get that baseline data. Another lesson that we have learned relates to staffing and facilitation of CST. Facilitators really need to have group facilitation skills and cognition, an understanding of cognition, not just group engagement skills. Social engagement and conversation is meaningful and valuable, but it's not the same as cognitive stimulation. And so facilitators really need the skills to both target those key principles and to drive the session activities towards those cognitive processes. We are finding that CST is a great onboarding program for people living with dementia, as it provides a real soft entry into programming. And it oftentimes it exposes to people living with dementia to their peers and others living with similar experiences for the first time in a supportive environment. And that's a wonderful thing to provide. Our successes include having high completion rates, as I've shared, and then re-engagement in additional programming. We've got positive participant outcomes and qualitative feedback. Our donors are actually really excited about this program, and so we're feeling like we can make this a sustainable option, for a sustainable and scalable option for folks. And it's really encouraging for our entire staff, as well as the facilitators, to meet with people living with dementia who are having such a positive benefit for our programs. There's a real difference in the input that you get back from a person living with dementia who's really excited and experiences this amazing sense of well-being, versus the caregiver who's really in those places of struggling. And so that's a nice kind of bright spot for our staff to have those experiences with people living with dementia. Next slide. Next slide. I want to close by sharing one case story of our program participants, and I'm going to show you a video here in a second, and Gary's language is a little muddled, so if you want to turn on your closed captions for that video, you can go ahead and work on getting that organized. But let me share by sharing Gary's story. So this is Gary, and he's given us permission to share his experiences. Gary's journey illustrates how CST really lays a pathway for a different future for the person living with dementia. Gary was in one of our first CST groups, which started back in 2022. And you can read along here with what his first CST group facilitator said about how he was when he first started with us. He was guarded, standoffish, limited engagement. His mood was fair and flat, and he really showed very little interest in the group members or the CST program. And over the course of the 14 sessions, he became much more engaged and connected with the group, and for the first time really began sharing a bit about his memory challenges. Gary finished CST and has continued to attend the weekly CST maintenance groups with us since 2022. And last year, he joined another 10-week psychoeducational workshop for people living with dementia that we have called Journeying Together, which then transitions into an ongoing support group. Gary's wife now is also engaged in our family support and education services. And this past spring, Gary joined our To Whom I May Concern program, which is a lived experience script writing workshop. And in April, Gary shared his stories in a public Reader's Theater style event at CaringKind. And I've got this 2-minute clip from that event for you to watch, and you'll hear how now Gary speaks openly to the crowd and to his children about some of his experiences of living with dementia. Cameron, can you play the video, please?
Thank you, Stephanie. And as she mentioned, please turn on your closed captioning located in the Zoom toolbar in case you are unable to hear the audio well.
Dear kids, I don't think I've ever had a proper conversation with you about my Alzheimer's. But I'd like that to change. Then again, who knows? Maybe I did. And I can't remember. So I want to make sure that I share some important things with you now in this moment. I want to tell you that it's a gift that we talk about this. That I trust you with this. I trust you that you will continue to love me. So, even though I'm not me, not really me, even though I am, I want you to be able to claim your own strength and ability. And to know that you are stronger than I am. I have faith, hope, and belief in you. I'm not a religious person, you know, but it's something to think about. We must say the things we want to say to those we love the most. Who knows? Maybe those weekly meditation sessions at the Rubin Museum have inspired me. That's why I wanted to share these thoughts and words with you. So let's talk about this more, if you want.
Thanks. Next slide, Cameron. So you can watch more of Gary in the full video of that performance on our website. And hopefully that gives you a better idea, better understanding of cognitive stimulation therapy and how we are implementing it CaringKind on our ACL-ADPI project. And thanks for your time and for your attention. And now I'm going to pass the discussion on to Kelsey to share about her work at CareLink. Thanks.
Thank you, Stephanie. He's a really tough act to follow, I must say. But thank you for having me. I am also excited to be here today to present on this topic, cognitive stimulation therapy programs and adaptations for specialized populations. We'll start at the beginning. Thank you, Cameron. As mentioned earlier, I am a speech language pathologist, also known as an SLP by trade, and I recently took on the role of program manager at CareLink's Center for Brain Health and Cognition. Next slide, please. We are grateful, of course, for the generous funding from the U.S. Administration for Community Living and Department of Health and Human Services that allowed us to launch these programs in our community. Next slide. So here's a little information about my company, CareLink. We are a nonprofit mission-based healthcare network and provider of post-acute and community-based services, serving older adults and adults with disabilities in Rhode Island since 1997. CareLink is a provider of inpatient and outpatient rehab services, dental, podiatry, audiology, behavioral health, and even wellness programs. We have recently established a Center for Brain Health and Cognition, and CareLink has expanded its community programs for individuals living in Rhode Island with Alzheimer's disease and related dementias and their caregivers. Next slide, please. So our ACL-ADPI grant funded from September 1st of 2021 through August of this year is titled Addition of Evidence-Based Clinical Interventions to Enhance and Expand the Current Dementia-Capable System in the State of Rhode Island. Our main goals for this grant were to close the gap in Alzheimer's disease and related dementias services by expanding upon existing programs that provide support and resources, and to add evidence-based interventions and rehab services to incorporate provider recommendations into the patient's home settings successfully. We also aimed to extend services to include individuals, populations in need, including individuals with intellectual and developmental disabilities, individuals living alone with a diagnosis of Alzheimer's disease and related dementias, and individuals with behavioral manifestations of Alzheimer's disease and related dementias. Next slide, please. So thanks to our ACL-ADPI grant funding, CareLink had skilled clinicians trained in 2 evidence-based programs to deliver in the Rhode Island community. These programs are called Skills to Care and Cognitive Stimulation Therapy. So Skills to Care Skills 2 care, is administered by specially trained occupational therapists who focus on helping the caregiver manage challenges associated with dementia through skill building, compensatory strategy training, education, and connection to community resources. It was chosen for the recognition and involvement of the caregiver as part of the team, and it includes education about dementia, approaches for behavior symptom management, effective communication, and ways for caregivers to care for themselves while providing the best care possible for their loved one. CST, cognitive stimulation therapy, is an evidence-based program for people with mild to moderate cognitive decline. And as Stephanie said earlier, has research demonstrating improvements in cognition, quality of life, mood, communication, and social engagement. And it was chosen due to its versatility of being provided as an intervention, either in groups or with individuals, and by existing CareLink employees, which are skilled clinicians. We have delivered a total of 28 in-person CST groups at various locations, including our own office location and local senior centers, and also at day programs for individuals with intellectual and developmental disabilities. Of these 2 groups, 2 were adapted for individuals with primary progressive aphasia, or PPA, and we'll talk about that in a bit, and are held on an ongoing basis. And 3 of those groups were adapted for individuals with intellectual and developmental disabilities. Next slide, please. So the following are some details about our in-person groups. We had many groups at our CareLink office site in the large conference room. Our conference room, I thought, is actually a great size. It has the best technology accessibility compared to the other sites we've hosted at. We have a large table in the middle, we have comfortable seating, and although we don't have a ton of space to move around, we're really able to capitalize on the multi-sensory experience at our office conference room with surround sound, a large screen TV, a whiteboard, as well as we're in close proximity to our outpatient treatment office for individuals who also receive outpatient services before or after the group. So many other groups were held at local senior centers throughout Rhode Island who graciously hosted us that we did outreach with throughout the grant. And some of them even hosted us for numerous groups at their site and asked us to present on other topics for their community members, and even contracted with CareLink to offer wellness classes as well. Our IDD groups were held at the day centers. The participants attended weekly, and their personal aides transported them by van from their homes. And overall, group attendance for our groups was pretty variable, but our PPA groups had the most consistent attendance and retention, with some members enrolled in the ongoing group over a year's time. Which I'd attribute just to the close-knit community and the support system that the participants and even caregivers developed over time. And I will speak more about strategies we developed to maximize efficiencies given the fluctuating attendance when we get to the lessons learned slide. Next slide, please. So although primary progressive aphasia, or PPA, is very rare, we received a large number of referrals for our programs with this diagnosis, 25 to be exact, in the tiniest state of Rhode Island, by the way. So we adapted our CST program to better accommodate these individuals. So here's a brief overview of what PPA is. It's a progressive decline in language. It is, in fact, a variant of frontotemporal dementia, which includes degenerative loss in the speech center of the brain. And when we think of language, it doesn't just mean talking. So language includes expressive language, or what we communicate out to the world. It includes receptive language, comprehending what others say. It includes reading and writing. And people with PPA may experience declines in any of these areas, which impacts their overall communication. Symptom onset is often before age 65. And the hallmark that distinguishes this from other types of dementia is the deterioration of the language before, often even years before, the cognitive decline. So in areas such as memory, safety, and problem solving. So it is not uncommon for people with PPA to continue to drive, work, grocery shop, and manage higher level tasks for long periods of time, but their communication skills really start to deteriorate and impact those activities quicker than their cognition. Next slide, please. And here are some adaptations we made to meet the needs of our CST group participants with PPA. We modified the frequency of sessions from 2 times a week times 7 weeks to once a week on an ongoing basis. We increased the use of visual aids such as photos, videos, and simplified written cues to support conversations, facilitate comprehension, and improve transitions. And by incorporating more of these visuals, this facilitated much more language generation versus with purely auditory information. And many people with PPA benefit from other methods of communication when they can't find their words, and they need other tools to help them. So we incorporated some of their personalized augmentative alternative communication methods, which is also known as AAC. There are high-tech AAC methods like speech-generating devices, and there are low-tech or no-tech methods like drawing or gesturing or pointing to a picture board. So the beauty of having SLPs facilitate these adapted groups for individuals with PPA has been that they have allowed for more opportunities to practice communication strategies that they were working on already with the SLP in outpatient, and more importantly, to generalize or carry over these techniques into group discussions and in everyday living scenarios. So SLPs recognize the need for strategies to facilitate turn taking, as these pragmatic and social aspects of language are also very impacted in this population, including insight, judgment, and self-awareness due to the degeneration in the frontal lobe of the brain. And one of the best outcomes that came out of delivering this group was the evolution of caregiver support groups that met adjacent to these groups. So the caregiver support groups were intermittently facilitated by a licensed mental health counselor and allowed the caregivers to share personal stories and really support each other as they navigated their journey with their loved ones with a very rare diagnosis of PPA. Next slide, please. 2 out of 28 CST groups were adapted for individuals with PPA and are held on an ongoing basis. 7 participants that initially enrolled in this program did not ultimately attend a group due to various reasons: transportation, lack of a caregiver, or even admission to the hospital. And for some, the location of the PPA groups, which were both held in the northern part of Rhode Island, was not close enough to their home, and they would not be able to make the commute. One participant was very young, and after attendance at her first group session, she felt that she just couldn't relate to the older people around her. Again, the nature of this disease is that it strikes much earlier. So sometimes even in the late 40s, early 50s. 67% of PPA CST group participants measured demonstrated an increased use of trained compensatory communication strategies through participation in the group, and 76% of PPA CST group participants had caregivers that enrolled in our other program, Skills to Care. Next slide, please. We have seen strong qualitative outcomes from caregiver report and in SLP documentation, including improvements in interpersonal communication, carryover of trained communication strategies with peers, renewed interest in participating in social activities outside the home, and improved pragmatic skills. And since PPA greatly impacts one's ability to comprehend and express language, the measures that were chosen as part of the grant initially were not appropriate to administer this population. So in the past few months, we determined that due to the nature of aphasia being a language disorder, we needed to consider an assessment tool which was standardized on individuals with aphasia. And we chose to add the Western Aphasia Battery, or WAB, to our toolkit. And the WAB is just an assessment for adults with acquired neurological disorders as a result of either stroke, head injury, or dementia. And it assesses linguistic and non-linguistic skills and helps to classify aphasia and establish a baseline of performance. Next slide, please. And this is some interesting data regarding the prevalence of dementia. So in individuals with an intellectual disability that are age 40 and over, 3% have Alzheimer's disease and related dementias, which increases to 6% in individuals age 60 plus. In individuals with Down syndrome that are age 40 and over, 22% have Alzheimer's disease and related dementias, which jumps to 56% at age 60 and beyond. Whereas in the general population, less than 1% have Alzheimer's disease and related dementias after 40 and 60 years of age. And one of our goals was to close the gap in services for persons living with dementia and intellectual developmental disabilities in our community, as they can and should have access to the same programs and supports. But because of diagnostic overshadowing, they often do not. So under our grant, we have provided interventions to 24 individuals with intellectual and developmental disabilities, which included 3 adapted CST groups. And some of these individuals were also referred to other programs we offer, such as the Skills to Care. Next slide, please. The following are some adaptations we made to our groups for individuals with intellectual and developmental disabilities. We recognize the need for increased support staff to maintain the group structure, dynamics, and flow. And we requested group members come with their direct care worker who provides the day-to-day care within their group home. So some had one-to-one aides and some had aides that supported several group members at a time. But this also allowed for educational opportunities and dialogue between the clinicians and their aides to review the CST principles and compensatory strategies to help facilitate improved participation and communication. And it also fostered some great opportunities for carryover into the daily living in the group home. We did incorporate more visual cues such as choice boards, visual schedules, and first then language, which was helpful in redirecting participants during perseverative moments and with behaviors and transitions. We use more real objects versus photos to provide more tactile stimulation to maximize attention and interest. And we created a group playlist instead of a group theme song where each participant got to kind of pick their own theme song to increase their interest and relatability amongst members, as this population tends to be a little more egocentric. So this fostered a lot of topic appropriate conversations, joint attention, movement, and reminiscence. And we even modified activities and focused more on some large gross motor movements and teamwork activities, such as the use of a parachute, and incorporated more breathing exercises into our warm-ups and cool down, like blowhorns, recorders, straws. And a key adaptation for this group was implementing transitions between activities to decrease overstimulation and disengagement. Some strategies we used were counting 1 to 10 or singing their preferred song lyrics and frequent visual schedule review. And additionally, we repeated or even invented some themes depending on the group interest. The most popular themes for this group were animals, fast food, music, sports, and childhood. Next slide, please. And as I said earlier, we adapted 3 CST groups for these individuals, which included 16 participants total. 1 out of 16 participants additionally enrolled in our Skills to Care program. 50% of participants measured demonstrated increased ability to follow directions during group activities and conversations, and 56% of participants measured demonstrated increased engagement in reciprocal conversation with peers in the group. Next slide. And as we worked with this population, we again recognized the need for adaptations. We recognized that the initial assessments chosen for this grant were not appropriate for individuals with IDD, and the qualitative outcomes were again the real star here. Additional outcomes included improved coordination of breathing and speech, which resulted in increased vocal intensity. Improved interpersonal communication. Some of these individuals started off day one and really kept to themselves, only spoke when prompted or with max cueing. And as the group progressed, there was a significant increase in spontaneous interpersonal communication. And we noted improved carryover between sessions, with some individuals recalling specific details and activities from prior sessions. And the most powerful outcome I witnessed was the improvement in transitions between activities with compensatory strategies that we talked about prior, counting or singing, and improved self-regulation in an overstimulating environment. Next slide, please. Now I'm just going to quickly switch gears and review the reimbursement side of things. As I said earlier, by utilizing skilled clinicians to administer these programs, we are able to bill our services through participants' Part B insurance benefit, which is important for sustainability of these programs when our grant funding ends. Each group session is billed using the group therapy code. So there's a speech therapy group code and an occupational therapy group code. They're both untimed codes, which just mean that each group member is charged for 1 unit of the code per group, regardless of the session length. And per Medicare guidelines, 1 therapist can bill up to 6 participants at this time per group session. And based on our individual physician fee schedule in Rhode Island, we receive approximately $18 per individual per group for the OT group code and $25 per individual per group billed by the SLP for the speech group code. And of note, travel, mileage, and costs related to documentation, time required to provide these groups around the state, travel, and whatnot, those are not reimbursed by insurance, which necessitates the need for more efficient practices. Next slide, please. So here's an overview of some of the challenges and our lessons learned and successes experienced in delivering these programs throughout the state. Among the top 3 challenges includes the non-billable costs associated with delivering these services, travel time, mileage, prep time, lingering participants and caregivers, and sometimes non-billable documentation. Sometimes we're able to coordinate individual sessions to complete our documentation and bill, but sometimes due to attendance, we're not. And many group participants' attendance fluctuates due to the mountain of other issues they may be dealing with in their personal lives or transportation, medical complexity. And data collection was also a challenge in working with both of these populations, as the assessments chosen as part of the grant initially were not necessarily appropriate, nor validated for persons living with dementia and intellectual and developmental disabilities, as well as individuals with primary progressive aphasia. So our outcomes were more qualitative in nature for these adapted groups. We did add that assessment battery in, the Western aphasia battery, and we would still need to include more appropriate measures validated for individuals with intellectual and developmental disabilities. Coordinating in-person groups at various centers throughout the state was a challenge due to busy center schedules, but we were often accommodated depending on their availability. And there were some participants who lived in outlier towns in Rhode Island and wouldn't make the commute to our locations. And if you know anything about Rhode Islanders, you know they don't like to drive more than 10 miles. And among the lessons learned include the need for more efficient group organization and enrollment practices. Due to fluctuating attendance, we were able to determine that enrolling 6 to 8 members per facilitator per group was the most efficient due to potential for multiple absences during any given group session, and sometimes planning on the smaller groups with 1 facilitator versus larger groups with 2 facilitators was more efficient. Additionally, there's caregiver education codes that were released, which allows us to make caregiver education without the person present, a billable service. So that gave us more opportunities to educate on CST principles, home exercise programs, and carryover activities. And then we identified that maintenance CST groups are indicated, and we are working towards achieving our first virtual maintenance group for people who complete one or more rounds of CST and are interested and appropriate. Of note, Medicare does cover ongoing rehab services to maintain or manage a beneficiary's current condition when no functional improvement is possible, if the services are medically necessary and meet skilled care requirements and aid in maintaining a patient's current condition or prevent or slow decline. And I'm sorry, I know we're kind of running out of time here. The last column are our successes, which I'd highlight in closing the gap in providing services for people living with dementia, and even these rare subsets such as PPA, offering these services to people with dementia and intellectual and developmental disabilities, and generating referrals for other service lines within our company. Next slide, please. Thank you so much for having me. It's been a pleasure to speak on this today.
Thank you both. Appreciate it. We're going to try and get to a few questions. Many of these questions were repeats of each other. I'd say we've got a lot of questions about after your funding is out from ADPI. Can you talk a little bit about how you plan to fund the program in the future? Kelsey, you talked a little bit about billing, but can you talk about your sustainability plan in a few words? We have about 3 minutes. We're going to try to get to 3 key questions.
Sure, I'll begin. So in a few words, our plan is to continue billing through that Part B insurance using skilled clinicians with efficient group practices. We are regularly scheduling groups all over the state and continuing to enroll 6 to 8 participants per facilitator per group to maximize our efficiency. And looking at the virtual options as well, because those are indicated to reach people who may not be able to travel to all those sites.
Great, thank you. And Stephanie, can you respond? And then Cameron, can you just advance 2 slides, please, to the last slide? Thanks.
Yeah, so like I was saying, we fundraise for everything that we do. And so this is definitely has appeal to a large number of our kind of ongoing donors. And I think the other piece is that we're just advocating in general for early stage services to be incorporated as a part of what is deemed medically necessary. And so, big vision is for ultimately services to be provided as kind of a wellness benefit under Medicare Advantage plans, and for insurance to actually cover services at a rate that makes them sustainable long-term.
Great, thank you. And Stephanie, do you want to just continue and talk a little bit? Is there a specific training for facilitators?
Yes.
And who can become a facilitator?
Right. So it is an evidence-based training. There is, so Dr. Spector, who's based at the University College London, kind of oversees the international work. St. Louis University provides training. There are a handful of us in the States that are actually licensed as trainers to provide training. I'm one of them. There's some folks at CareLink who are also trainers. And so training is required. What are the qualifications? If you're doing it under a billable service, you have to be a clinician to do that. You don't necessarily have to be a clinician to do it. But as I was saying in our lessons learned, and part of the challenges is that there's a certain skill set that you really need in group facilitation and in understanding cognition in order for this to be really truly cognitive stimulation versus just a social engagement group. And so I think that, having, a certain level of education or clinical experience working with this population is critical to that.
Great. And then Kelsey, can you just say in 30 seconds or so what you suggest care partners do during the CST sessions, how you involve them in other things, or what the typical plan is?
Sure. So we oftentimes we have the caregiver support groups that naturally formed to provide reciprocal support to each other within their community. But when we provide the caregiver education sessions and we pull them into the group, we might give them kind of like a written recap similar to what Stephani does virtually, about what the session or the sessions have covered, takeaway points, brain health, general wellness tips, and ideas for what we refer to as home exercise programs or carryover activities to take away into the home environment.
Great, thank you so much. Well, that's all the time we have today, everyone. I want to thank you all for joining us at the National Alzheimer's and Dementia Resource Center webinar series. Our next webinar is the experience of younger onset Alzheimer's disease and the importance of community support on September 16th. If you haven't received the registration information yet, you will get it through email in the next few days, and we hope you can join us. You can contact us at NADRC-webinars@rti.org if you have any questions. Thank you, Kelsey and Stephani, for your fabulous presentations. We appreciate you, and we will see you all soon. Take care.
Thank you.
Thank you.